So we do have a solution that's been developed in Nova Scotia for people that have multiple chronic conditions and environmental sensitivities. This, as we know, not only through research, but from experience, is a growing problem and a trend. So obviously the literature supports it, but experientially, we know that people are getting sicker, and that's because of our current type of lifestyle. We have tighter building envelopes. That means we are keeping all our indoor chemicals which we use, which is also increasing, inside the building. So you can look at office spaces where people are working for prolonged hours, as well as people who are staying at home. You're receiving constant exposures. So in our experience in working with people, we did decide and we did know that we had to come up with solutions. We also had a local context in Nova Scotia where the government was also forced to respond because a whole bunch of healthcare workers fell sick in a sick building syndrome. So that raised the political awareness of the issue, and with that, the healthcare system did respond. We did come about as a research facility. We were called the Nova Scotia Health Center. But following that, we realized that there was a mandate to treat the patients. It was not just about research. So we became part of the health system. Now, it has not been an easy journey for us because we have had to establish not only the fact that these are real conditions, the experiences are real, but we also have had to establish that we are doing something good. We are making a difference. So in our journey, we have tried to figure out what is it that's most important to people, what is it that's most important to our government, and what is it that's most important to our health system. So from a person, it's important that you're able to function. You're able to return to what you can do. You're able to return to your work. From a health system, it's important to show that these people are getting better, which means that they're not using our emergency services, they're not using our hospital beds, and that people are returning to work. For the government, all of this is important. They want a healthy population, they want that people are returning to work, and they want that our hospital costs are lower. So with that in mind, our model and our whole way of delivering care has been evolving, and we constantly listen to our patients and what they bring to us as their experience, but we've also engaged key stakeholders, our health system, policy makers, decision makers. We've also had our government involved, and we are fortunate because our government has been listening to this, because they see the impact of not listening. Not listening means your costs are going higher, because people are not at work, sick time rates are higher. So with all this, the model has evolved very well. We have also had a chance to contribute towards multimorbidities, because when you think of people that have multiple chemical sensitivity and they have overlapping diagnosis of chronic fatigue syndrome, fibromyalgia, you're already looking at a cluster of diagnoses. So our model of care has really evolved out of those multiple conditions. So this model is now being cross-applied across the health system to help people that have multiple chronic conditions. So we really have, kind of branched out into a dual role, one for individuals that have environmental conditions, but also for people that have multiple chronic conditions. So as a health system, we are well recognized, we have won multiple awards for that, and our patients are feeling better. So our integrated chronic care service is really a model that is helping people functionally manage their condition, but also a rehabilitation approach where we are helping people return to work. And also we talk about self-management. We think of it as a chronic disease management, so that helps us be globally understood as well. So we do collaborate with workplaces for rehabilitation. In a recent review that we did with our patients, return to work was identified as a top functional health goal. We do let patients self-select their functional health goal, and we do this by using the Canadian Occupational Performance Measure. And interestingly enough, return to work showed up as a top category for functional health. And it's interesting that the Finnish work that has happened has also identified return to work as a top goal. So this is kind of contrary to the belief that people want to stay off work or get paid when they're not working, because that's not the case. Most of our patients are high achievers. They are academically strong, they want to get back to work, they want to be useful contributors in the society. So given that is a fact, so we feel that one of our primary mandates is to support that rehabilitation as well. So along with functional rehabilitation, which is for all our patients, we focus on the workplace rehabilitation. So as we know, this is a complex process. We cannot do it by ourselves, or the patient just cannot do it on their own. So we collaborate with workplace and employers. So over the years, we have understood how to communicate better. So part of the fear that employers have is that we are all of a sudden going to ask them to make major changes, that there are going to be cost implications. But really, we work with a very practical approach. So we tell our patients that our primary area of focus is working with their changes at the personal level. So that means patients are building their coping and their capacity to return to work. And then we work with the employers to build their capacity to accept this patient. So when this person goes back, they have to be in an environment that's supportive, which means the employers have to be supported in that. So we do 2 tiers. One is we educate the employers, and they may pull all their employees in, and we talk about a healthy workplace environment. That means reducing the scents that may be in the workplace or products that may have chemicals in it. And in Canada, and I'm assuming that kind of the movement is there, that we are all now aware that having lower levels of exposures to chemicals in indoor environment is better. So most workplaces are already open to that. We also try to package that with healthy eating so that employees feel like we are kind of bringing the whole picture. And we know that diet is much more acceptable. We have a lot of gluten-free environment and everything. So we try to package it in a way that it's useful to the employees when we do the education session. And so once we do that, we also give a session where we kind of open the floor to let the employees ask any questions that they may have. So almost making it a safe environment, because we hit questions like, how come this person is reactive today and they were okay yesterday? So we talk about how there's a boom-bust pattern and the fluctuations in the reactivity. So we almost give a chance so that anything that could come to the person who's returning to work directly can be taken by us, so that we are answering as the experts in the field versus the person being put in that position of having to receive these questions. And at the employer level, we talk to them about how to make practical changes to the workplace. So examples are teachers in schools, where it's a very challenging environment. It is again tight building, and students are quite centered, especially if you're working with teenagers. And the challenge is that the school has limited control over how students show up. And so we try to go in there and talk about healthy workplace environment. We educate the students on, using products that are probably less scented or with lesser chemicals. And we talk about how it's important to them as well. We also talk to the teachers working with the individuals so that they can understand the importance of being supportive, understanding the fluctuations in symptom patterns. And for the employer itself, it's important to understand what type of changes they can make. So our occupational therapists will do a complete assessment of the workplace, come up with some practical strategies. For instance, for the person, we talk about taking enough breaks. That means the employer has to give permission for that. And we show them results of how a person can be more productive if they were to have short breaks to go out, take a walk, come back, or have a space where it is, cleaner environment so they can take a break and come back and be productive. And also it could be some of those accommodations such as air purifiers, air filters, or windows that can open. So we give them some practical and doable steps. And sometimes we also show them how they can do it in phases if the financial implications are big. And we've had very positive response to the way we have worked with them, because it's not that we are just pointing out the problems, we are also proposing the solution. So we've had enough of recognition that now other workplaces will just call us to do education, even if there's no patients that have come from there. So we've had this from the university environment, we've had it from the military. So this is very encouraging for us. That means the culture is shifting. But return to work is by far the biggest success we've had. So over, in the patients that have wanted to return to work, we have greater than 75% that are successfully rehabilitating. So that's a big success story for Nova Scotia. So we've been able to build a rehabilitation system, and part of it is to be able to justify it economically. So the way we look at it is, what is it costing the health system? That is the number one question, because we have to be able to justify our existence as a service. And in Nova Scotia, the nice part is, as a health system, we don't ask just of one or two service, because we are acknowledged as a service that does chronic disease management. We are alongside of the diabetes management centers, COPD clinic. So that means all of us are justifying the same way. What is it that we do? How is it economically justified? So we all have some standard measures, and this is not unlike other regions and other areas across the world. So what is the biggest impact for the health system? It is the use of emergency services. It's the use of hospital beds. So what we have been able to show is, we did a study where we looked at X number of patients and we asked in their self-report how the emergency utilization has been. And that's one thing. And we can also get data from our emergency clinic. So we have been able to get that to say, before intervention, what was the utilization like? And after intervention, what was the utilization like? So we've been able to show significant changes in how people went to emergency service. So if you look at it, when a person has any type of symptoms, and we know patients with MCS can have significant functional limitations, but also when they do experience an exposure, how that impacts their symptoms can be quite severe. So when you don't have a service, or when your health center may not be able to support you, your immediate tendency is go to the emergency clinic to get help. So that means they are going there not because they could not do anything else, they just don't have the access to the service that can support them. So by providing something that will come in the way of the emergency service, you're able to reduce the visits there. So that is what we were able to show. When they had an intervention that was available, when they could get the validation for what they were experiencing, they started to reduce their use of the emergency service. So that was one layer of work we have done, and we have shown that there are significant changes post-intervention. The other thing we have done is really to look at what about the physician visits and the specialist visits. So not only are the patients hopping from specialist to specialist and having multiple types of tests done, their visit to their physicians, or as you have here, health centers, is also high. Because when your physician or your health center doesn't understand what's happening with you, you keep going back to them. And if you're listening in 5 minutes and trying to understand what's going on, you probably have not solved anything. So what we saw before people came to ICCS or the Integrated Chronic Care Service is that their physician visits used to be very high. The visits to specialists used to be very high. But after our intervention and after we worked with them on the self-management strategies, the visits were lower, significantly lower. So we have published this. We are also going to publish the ED visit utilization. So what we're showing in the health system level is that patients are using lesser service, so the costs are going down. At the rehabilitation front, in terms of the return to work, we are also showing that patients are returning to work. That means less sick time costs, more productivity for the workplace. So that's the other cost savings. And as a service, we are quite lean because we don't work in isolation, we work in a collaborative care model. So for instance, we don't do what people have to do. So we work with, for instance, the pain management clinic who deal with chronic pain patients. So when patients are experiencing pain, as long as it is part of our portfolio and our work, we treat that. But if we feel pain is a major complaint, we then cross-refer them to the pain management clinic. Likewise, we address the psychosocial effects of the chronic disease management, which MCS patients have, so do diabetes patients. But if there are mental health concerns, we work with the mental health clinic for that. So we are in a collaborative care model, and we also build capacity in the health centers or the family physicians so they can support self-management. So as a service, we are very lean as well. So if we look at all of these together, yes, there is cost savings at the individual level because the person is now functionally able to lead their life. We are also supporting the health system, but we are also supporting the government because Nova Scotia has the highest disability rates, which means we are contributing in reducing disability. Chronic disease management is a major concern, and multimorbidities is a major concern. So we're hitting all those targets by supporting this patient population.